All right, can everybody hear me okay? I am Rachel. I think I've spoken with probably everybody on the line today. I'm Rachel, the local Boston Scientific patient education rep in our area. I work with Dr. Henick and Dr. Fox, who are going to be speaking today. I'm going to be keeping an eye on my cell phone. So if somebody cannot hear, feel free to shoot me a message. You can also use the Q&A box that you'll see on your screen to send that. We want to make sure you can hear and see everything clearly. Just a couple housekeeping things before we get started. No one can see or hear any of the patients on the Zoom today. So you'll be able to see and hear us, the speakers, but no one can see you. So everybody's privacy is protected there. We just want to make sure you're aware of that. Also, I'm going to put up a screen here. Most of you know these guys. This is Dr. Henick and Dr. Fox with Sports Medicine Orthopedic Center. That's who's going to be speaking today. And we also have Sandy, Miss Sandy on the line. She is a patient who is managing her chronic pain very, very well. So she's going to share her story with you at the end. And then we'll take some time for question and answers. So again, feel free to use the Q&A box to type those questions in, or you can text me. My number is going to be right here. I'm Rachel. Text me or email me. For the sake of time, we're going to keep this to an hour. So if we don't get to all the questions, just know I'll be following up with anybody who submitted a question. So don't feel like you were left out. We're just going to keep this promptly to an hour. Let me make sure we've got everything. All right, without further ado, I am going to pass this on to Dr. Henick to talk to you today.
All right. So, hello everybody. My name is Dr. James Henick. I'm the interventional pain doctor here at Sports Medicine Orthopedics in Suffolk. I'd like to thank you all for joining us. I'd like to thank Boston Scientific for sponsoring this virtual meeting. So we're going to talk about spinal cord stimulators. Most of the talk is going to be focused on spinal cord stimulators. So I'm going to get right into it. I'm going to go through the process of what you can expect when you come in to be evaluated for a spinal cord stimulator. So you're going to come into the clinic, and the first thing I'm going to do is a history and physical exam, as any good clinician would do. So there's three major things I'm going to ask you about your pain. First thing I'm going to ask you about your pain is how long have you had this pain? We are looking for people that have pain for months to years, maybe even decades. If you have had pain only for weeks to months, you're not a candidate for a spinal cord stimulator. So we're definitely looking for people that have had pain for a very, very long time. We have other options available to you if you have had pain for only weeks to months. We have a number of different interventional options for you for this other kind of pain. But we're looking for pain of very long-standing duration. The second thing we're looking for is the quality of your pain. We're looking for people with pain that is burning, lancinating, sharp shooting, electric pain, throbbing pain, spontaneous pain. So spontaneous pain is pain that arises just when you're sitting still and not doing anything. This is called neuropathic pain. This is the pain that spinal cord stimulators are wonderful at treating. If you have aching pain, like an aching, throbbing toothache pain, stimulators are not going to be indicated for you. We're looking for neuropathic pain. The third thing we're looking for is the location of your pain. We're looking for people with geographically isolated pain. So in other words, arm pain, leg pain, low back pain, neck pain, pelvic pain, abdominal pain, but basically geographically isolated pain. So in other words, if you have fibromyalgia pain, where you have pain all throughout your body, stimulators are not going to be indicated for you. We're looking for very isolated pain areas, okay? All right, that's the kind of pain that we're looking for. I'm going to give some specific examples of different pain syndromes that stimulators are very good at managing. So the first one is post-laminectomy pain. So this is the most common indication for spinal cord stimulators. Probably 70% of our patients that get stimulators have post-laminectomy pain. They've had surgery on their back or their neck. They have had hardware placed, or sometimes not even hardware placed, but they've had operations. Some people have had one back operation, some people two. The person that I have seen the most number of operations on their back, they had 7 back operations. They got a spinal cord stimulator and they did very well. So what happens after you have had spine surgery is that the surgery itself is very successful. The patient's been stabilized, the back has been stabilized, but unfortunately, the body responds to surgery or trauma by forming scar tissue. So you end up with scar tissue inside your spinal canal, scar tissue wrapping around your nerve roots, called cauda equina. It's called arachnoiditis, nerve clumping, different types of disorders like that. Spinal cord stimulators work wonderful for that kind of pain. The second one is complex regional pain. Complex regional pain is a pain syndrome where the body just sort of goes haywire. The arm or the leg will get very swollen, very atrophied, get a lot of contractures, a lot of skin discoloration, stuff like that. That's called complex regional pain. Very responsive to spinal cord stimulators. The third one is scoliosis. People that have scoliosis. This slide illustrates spinal cord stimulator in place for someone who has modified or moderate scoliosis. Stimulators can work very well for this type of pain disorder. We actually, in the past year, have put in a spinal cord stimulator in a lady that had scoliosis that was so dramatic, her back looked like the letter S. It was completely bent over. We did a spinal cord stimulator and it worked out very wonderful for her. Spinal stenosis is another indication for stimulators. The only caveat to that is I make sure, as in all of my patients, that you're not a surgical candidate. We need to make sure before we put in a stimulator that you don't need surgery instead of a stimulator. If you need surgery, then a stimulator is not going to help you. I will work with Dr. Fox to assure that surgery is not indicated for you before we do a stimulator. But spinal stenosis is a great indication for stimulators as well. So some other pain disorders, chronic pelvic pain. So people with chronic pelvic pain, they've had perhaps hysterectomies, they've had oophorectomies, they've had other pelvic pain disorders and pelvic operations. They're left with pelvic adhesive disorder. Very good indication for spinal cord stimulators. People with chronic abdominal pain, again, people that have had a number of operations on their abdomen, chronic pancreatitis, good indication for stimulator. People with thoracic pain, when a surgeon goes in, operates on your lung or your heart, they got to make a thoracotomy incision, they have to spread apart your ribs. You end up with chronic intercostal pain of your thoracic area. Good indication for spinal cord stimulator. Peripheral nerve pain, especially diabetics, is another great indication. So any of these disorders can be very good for spinal cord stimulators. So very briefly, I start from less invasive to more invasive. As far as treatment options, whenever you come in considering a spinal cord stimulator, I assure, have you tried less invasive options first? Physical therapy, acupuncture, chiropractic care, different types of non-steroidals, Tylenol, ibuprofen, Motrin, Aleve. Just make sure that you tried them and you failed them. Chronic pain is the same as neuropathic pain, same as nerve pain. So we prescribe neuropathic agents. Neuropathic agents are agents like gabapentin, Neurontin, Lyrica, pregabalin, Trileptal, Zonegran. All these medications are neuropathic medications for nerve pain, which I guarantee that chronic pain patients have. They're also anti-seizure medicines, one and the same. So we will prescribe them, see how you do with them. We try to make sure that you've tried different TENS units, electrical stimulation units that you place on your skin. Some of these are also called Zynex units or H-wave units. These can help you very much. Different types of injection procedures, epidural steroids, etc. We try them and make sure that you have tried them. Different types of ultrasound guided musculoskeletal injections that can help you quite a bit. We may try them as well, okay? So the other thing that we try that can help you very much short of a spinal cord stimulator is radiofrequency ablation. So we use heat to turn off little nerves in your back, in your neck, in your hips and shoulder, knee, wherever the pain may be. These can be very effective before trying a spinal cord stimulator. Excuse me. So let me go through the process of a spinal cord stimulator trial. Okay, it's a two-part process. I do the first part, which is the trial. Dr. Fox would do the second part, which was the device implant. So you come in, we usually give you 4 Valium tablets, 3 to 4 Valium tablets. So you're sedated. You don't need conscious sedation. We don't do that. But you come in, we place you on the procedure table, face down. You're nice and relaxed. I numb up 2 areas in your back. I use a lot of numbing medicine. I put 2 needles through the numbed up areas. The needles go into the epidural space. The epidural space travels around your spine from the neck all the way down to the tailbone. So I get into the epidural space, and instead of putting in medication like steroid, which a lot of you have had, I put 2 stimulator leads through the needles, and I guide them about halfway up your back with X-ray guidance, okay? Then I pull the needles out. I leave the stimulator leads in place. I wrap them around your back to your front. I put the ends of the leads into a battery, and you clip the battery to, excuse me, you clip the battery to your belt or your waist, and you're going to wear it for about 3 to 6 days. The battery produces a little bit of electric current that produces a buzzing, tingling, a massage type feeling, a very pleasant feeling. And what you feel is that buzzing and massage feeling. And what it does is it dampens down the pain. So the pain signals don't travel up to your brain, they get suppressed, okay? After 3 to 6 days, you come back into the clinic, and I just pull the leads out. It takes all of 20 seconds to pull the leads out. And if you get 50% relief, then I refer you to Dr. Fox to consider putting the device in permanently. So if Dr. Fox puts the device in permanently, he has you go to sleep in the operating room, usually at the surgery center. Makes 2 small incisions in your back, usually about 1.5 inch each incision. He puts the device in. Most of it goes underneath the skin. only a very small part goes next to your spine. It takes them about 45 minutes to put the device in permanent. It can stay in for 10, 15, 20 years. It gets reprogrammed and recharged right through the skin. So there's no more operations. They can be very, very effective. So it's minimally invasive, it's reversible, it's non-destructive to tissues. It's a neuromodulating device, meaning we don't cut any nerve tissue, we don't destroy any nerve tissue. We modify how the nerve tissue is functioning, okay? This is a spinal cord stimulator lead in place, just to show you. So again, we use oral sedation. Patients are nice and comfortable, relaxed. Usually takes me about 45 minutes to do a stimulator trial. You're relaxed, but you're interactive with the staff. We do the testing right in the procedure room. We create the numbness tingling sensation, and we want that to overlap your pain area. So that is called a paresthesia. So we want the paresthesia to cover the painful area so that you get the best effect. It's usually a 3 to 6 day trial. We give you antibiotics. You just want to limit activity somewhat, no excessive bending, twisting, lifting. You return to the clinic for the lead pull. This is a device already in place and taped onto a person. So this is very effective. We can get usually at least 50% pain relief. A lot of times 70, 80% pain relief. It tends to be a very, very effective measure to control chronic intractable pain. It's very safe. It's been in use for over 60 years. It's FDA approved. It's covered by most insurances, if not all insurances that we would use. Okay. And our goal is to, anytime you come into an interventional pain clinic, our goal is to take down your pain 50%. Oftentimes, we find that with stimulators, we're taking down your pain 70 or 80, sometimes even 90%. So they tend to be very, very effective. Okay, the last slide that I'm not going to get into a whole lot is your comorbid medical issues. Your heart, lung, liver, kidney disease, brain issues. I have to make sure that all of these other medical issues are stable and well controlled before we do a stimulator. I got to work around blood thinners, antithrombotic medications, all the other medications that you take to thin out your blood. We got to get permission to stop these medications for the duration of the stimulator trial, just to be on the safest side. And that's it. Thank you.
All right, thank you, Dr. Henick. Now up, Dr. Fox, he's going to talk more on the surgical side. And remember, we will hear from a patient at the end, and then we'll have a short time for question and answer. And I already see some questions in the Q&A, so perfect. All right, Dr. Fox.
Thank you, Rachel. And as you mentioned, I'm Dr. Brian Fox. I'm an orthopedic spine surgeon practicing at Sports Medicine Orthopedic Center, predominantly in our Suffolk location. What I'm going to talk about this evening in overview here is, first off, my role as a surgeon, and then what conditions are there that surgery might be indicated and might be helpful. A brief little discussion of the different types of spinal surgery and how well some of those work for certain conditions. And then finally, a little introduction into my thoughts anyway on when surgery might be a better option than spinal cord stimulator or vice versa. My role as a surgeon, first off, is to ensure that any surgical conditions are evaluated and that we have an appropriate discussion about surgery if it would be reasonable. And then also to understand and appreciate the limitations of surgical intervention. There are a lot of folks who have abnormal MRIs, abnormal X-rays, and may have pain, But there are limits with regards to what I can do as a surgeon. And I have to understand that I'm not just there to change the appearance of an x-ray. I actually want to make people get better. And then in those appropriately selected patients, provide quality surgical care. And I have a whole team of people who work with me to make sure that that happens in the operating room and afterwards as well. And then here in the office, I serve as a team member in the integrated approach to patient care. And the other members of the team, you just met one of them, Dr. Henick, but we have a number of other providers here who serve on that team to coordinate all different aspects of spine and chronic care or chronic pain care. And then finally, if it goes down the path of spinal cord stimulation, as Dr. Henick mentioned, I'm the one who would likely be implanting that. In folks who have pain, and in particular chronic pain, the first step in the process is to figure out what's the source of the pain. And that's not oftentimes an easy endeavor. Sometimes it is, but many times it's not. And with regards to the spine in particular, we have a number of different structures that we get concerned about, starting with the bones. We have fractures that may occur. Just simple osteoporosis can be a painful condition. The discs are oftentimes a source of discomfort, not only in the back or neck, but the arms and legs as well. The joints that line the spine, the facet joints, can be arthritic, just like a knee joint or a hip joint can, and they can be a source of pain. And then the nerves, this is a big one. This is where I get involved most of the time, when nerves get compressed, causing pain, numbness, weakness. And then finally, the muscles can also be painful. And as a surgeon, there's not much I can do about that, but I do need to recognize that they can be a source of the pain. We start out the evaluation process with a history and an examination. And really, I get about 90% of my information from listening to the patient and getting an idea of the nature of their pain and the things that make it better, the things that make it worse. And then we add to that potentially some x-rays, which we almost always get on an initial visit early on. Based on that, we may start treatment, or we may decide that we need something a little more advanced like an MRI or a CT. That may come later as well. And then another powerful tool that we have to help diagnose and treat pain is selective injections. And these might be epidural injections, they might be joint injections, trigger point injections. There are a host of different injections we can do to serve two purposes. One, make the patient feel better, and number two, help us figure out where the pain is coming from. Once we start treatment, we try to keep it simple and safe at first. So usually there are conservative treatment measures that we'll try, which would include modifying activity. There are certain activities that are painful. We try to find other things to do that aren't so painful and avoid those provocative activities. From a medication standpoint, there are a number of different classes of medications, including over-the-counter medications and prescription medications that can affect anti-inflammatory properties, muscle relaxers, nerve medicines, steroids, and then straight up pain medicines, both of the non-narcotic and narcotic variety. For the most part, we don't make a habit of prescribing a lot of narcotic medicines. Those tend to be reserved mostly just for my post-operative patients for a short period of time. Continuing on down the treatment pathway, physical therapy and other adjunctive therapies such as chiropractic and acupuncture play a big role in what we do for many patients. So we have relationships with a lot of therapists that we can get folks in to see, as well as other specialties there. As I mentioned a few moments ago, injections can make up a large part of what we do, both from the diagnostic standpoint as well as a therapeutic standpoint. I do a number of injections, but really my go-to guy is Dr. Henick. He's the expert in a wide variety of different injections and where the best injection would be, and more importantly, how to make that happen. And then at the bottom, surgery, that's where I really come in. If it's a condition that would benefit from surgery, that's when the patient and I have a discussion about that. With that in mind, what are some of the indications for surgery? And by and large, with regards to the spine, the number one indication for surgery is a compressed nerve. And there are a number of different names for that: spinal stenosis, radiculopathy, sciatica. all of them referring to a nerve that's getting pinched and causing pain. And that pain typically radiates from the back or the neck into the leg or the arm. And that's the sort of thing that sometimes responds well to medicine, but oftentimes goes on to need surgery. And the results for that surgery tend to be pretty good. I'll get into that in a bit. Another large category of things that are amenable to surgery is instability. And that runs the gamut from patients who've been involved in high energy trauma and have broken bones and torn ligaments to degenerative conditions such as spondylolisthesis and even scoliosis. When the spine is unstable, there aren't many medications or therapies that help much with that. It oftentimes requires some sort of mechanical stability to fix that, and that's where I come in. Tumors and infections are relatively unusual, but in most cases, those do have some indication for surgery. And underlying all of these is that there needs to be pain with an identifiable source. I need to be able to tell where the pain is coming from before I can say, taking a scalpel to this will make it better. And that pain shouldn't just be mild, it really needs to be significant or intolerable. And in most cases, it has failed to get better with all other conservative measures, medicines, injections, therapy. In most cases, surgery is a last option. And then finally, the symptoms have to match what we see on imaging studies. Many times, folks will have imaging studies such as an MRI that show degenerative discs, but those aren't really the source of their pain, and the disc that's on MRI that looks horrible doesn't match up with the symptoms. So you have to put the patient first and use the imaging studies to verify that what the patient is experiencing is actually represented on those imaging studies. The general types of spine surgery that are out there that I do or available anywhere for that matter. Number one, lumbar decompression. And this is a relatively simple surgery with short operative times and typically a quick recovery, the goal of which is to relieve pressure that's on a nerve. In most cases, that pressure is from a disc that has either bulged or herniated. And that's not all cases, but that's the most common one. And that's what the cartoon there is showing. It's showing a disc that is bulged backwards and is pushing on the sac of nerves there. And we like to equate that to a jelly donut. Anytime I can put food into the mix, I'll do that. And in this case, the jelly has come out of the donut. So the surgery involves going in and plucking out that bit of jelly that's not where it's supposed to be. We call that a discectomy. Laminectomy is another procedure done for similar reasons, where we remove some of the lamina, which is the bony roof that covers the nerve. And this is usually done as an outpatient surgery. In my practice, that usually means that it's done in the surgery center, but sometimes in the main hospital. And oftentimes that's same-day surgery, go home that day. Sometimes it does require an overnight stay. Moving on up the scale of complexity is a lumbar fusion. And lumbar fusions can take a number of different modes and extents. Some of them are a single level where we're fusing just two bones together. Others involve multiple levels, like this picture shows, with screws in 5 different levels. There are many different ways to approach this. It can be done from the back. There are certain cases we can do through the abdomen. Other cases we can do through the side. In most cases, a fusion surgery also involves a decompression, the surgery that I mentioned in the previous slide, to remove pressure off the nerves, but then needs additional treatment with some sort of device to stabilize it. And that stabilization is usually done with screws and rods like you see in this X-ray. There are also spacers placed in the disc space here, which is another option or additional type of procedure that's usually coupled with it. In most cases, this represents a 1 to 2 day hospital stay, but in more extensive cases, it can be a little bit longer than that. Moving on up to the neck, a cervical discectomy and fusion is really our workhorse for neck conditions that involve compression of either the nerve roots coming off of the spinal cord or compression of the spinal cord itself. And this might be a single level like is displayed here on this x-ray, or it could be multiple levels depending upon how advanced and how extensive the disease is. This surgery is, in the overwhelming majority of cases, a single day hospitalization, come in the day of the surgery, go home the next day, and relatively rapid return to most normal activities. Outcomes for surgery, they vary widely depending upon the severity of the surgery, the severity of the condition, what surgery needed to be done, how many different levels were done, and then the other comorbid conditions that the patient may bring with that. The part of the pain pattern that tends to respond best to any spinal surgery is arm or leg pain that is due to an irritated nerve. That's the part of the condition that I generally give very good prognosis for improvement. Back pain and neck pain that might be associated with that, the results are a little bit less favorable. In the case of a lumbar laminectomy or discectomy, I quote about 80 or 90% relief of the leg pain that's associated with it, but minimal relief of back pain. And that's usually on the order of 30 to 40%. Laminectomy or discectomy is not a procedure done to relieve back pain. It's a procedure done to relieve the leg pain that's due to the irritated nerve. Now, I don't know if this woman in the picture ever had back pain or ever had surgery, but I was just so impressed with her skill set that I had to put her picture in my talk. Moving on to cervical discectomy and fusion, that also is done predominantly to relieve arm pain, about 85 to 90% success rate with regards to that. Neck pain, about 60 to 70% relief. And sometimes patients also have associated headaches, but that's not the reason we do this surgery. 50-50 with regards to the headaches. We don't do the surgery for headaches, but if the headache gets better after the surgery, I'll take credit for it anyway. The picture there on the right, that is Peyton Manning when he's playing for the Broncos. And any of you who follow professional football might be aware that he did have neck surgery. He did have a cervical fusion. And after that fusion, he played in 2 Super Bowls and he won one of them. So that's a testament to the degree of relief and recovery that we expect from this type of surgery. Lumbar fusion, once again, best relief, best benefit with regards to the leg pain, because most of the time we do this procedure because the nerves are getting compressed and there is instability. So very good relief with results for leg pain symptoms. About 50 to 70% of back pain is relieved. And much of that depends upon the condition we're trying to treat. This is a much longer recovery than any of the other 2 categories I mentioned. Typically 6 to 12 months to get a full recovery back to full activity without restrictions. But in most cases, we can get you back to full activity. The gentleman on the right, that's Tiger Woods. He used to be my poster boy for the laminectomy side of this because he had a laminectomy and had done well. Since that time, he has gone on to have a lumbar fusion and did win the Masters after having that. So once again, a testament to the level of relief and return to activity that is possible after this sort of surgery. Now on to the last section here, surgery versus spinal cord stimulation. And it's my opinion that spinal cord stimulation is the best option when we've exhausted other options, and those would include surgical options as well as injection treatment, medical management, the host of things that we've tried. When they don't work, spinal cord stimulation is the best option. And in general, if there is a condition that's amenable to surgery, that's usually the preferred treatment. Now, if the surgery fails to give adequate relief, spinal cord stimulation is almost always an option after that as well. Matter of fact, one of the primary reasons that patients come through our office here and seek spinal cord stimulation is if they have failed a back surgery or have had multiple back surgeries and are left with what we call a post-laminectomy syndrome, which is chronic back pain that we believe is related to multiple spinal surgeries. Unfortunately, that is not an uncommon condition. And I know Dr. Henick has already run through this, but I'll go quickly over it as well, just the basic essence of how spinal cord stimulation works, and then a brief review of how the process of getting one implanted is. Here on this cartoon, item number 1 is indicating the pain path that goes from your back, or wherever the pain source is, up to the brain. Number 2 is the battery pack that is also the pulse generator. That generates the electrical impulses that then travel up the leads. And those leads and the pulse that's generated causes that paresthesia that Dr. Henick mentioned, that, for lack of a better term, covers up the pain signals or modifies them to the point that they're perceived as just a pleasant tingling sensation. As was mentioned before, this implantation is a 2-step process. If other treatment modalities haven't worked, then we get you in for a trial stimulator. And that's an in-office procedure that Dr. Henick does. You wear it for 3 to 6 days. And if it works well, and for this purpose, we define well as greater than 50% relief of your pain, then you're referred to me for the implantation of the permanent device. That is a formal surgery with general anesthetic done in our surgery center, 45 minutes to an hour typical surgical time, with 2 incisions, one in the middle of the back to place the actual lead, and then another usually in the flank or the buttock to house the battery pack. Minimal restrictions after the surgery. I do restrict bending and lifting for about 2 weeks, just really to let the surgical incisions heal. And after that, then there are essentially no restrictions. We do the initial programming in the recovery room, and then additional programming and reprogramming is done in the office on your follow-up appointments. And Rachel assures me that they're available 24/7, 365 by cell phone to accomplish additional programming if necessary. And she's laughing over here as I say that. All right, and that's all I have. We'll have our patient ambassador up next.
All right, thank you, Dr. Fox. And we are available quite often, but not 24/7. Real quick, I'm going to launch a quick poll. You're going to see it pop up on your screen. It will just ask 2 questions. If you could click yes or no for those, it'll help us kind of know the best way to follow up with everybody. We're going to give that just a second, and then we will introduce Miss Sandy. Got lots of answers coming in. All right, while we're finishing that, I'm just going to introduce Sandy. Sandy is a patient of Boston Scientific. She is a complete 100% volunteer. She is not paid to speak for us. She just has been able to manage her chronic pain and wants to share her story with patients just like yourselves. So I'm going to welcome her. She's going to talk for a few minutes, and then we will go over some question and answer. Welcome, Sandy. Thanks for joining us.
Thank you, Rachel. Yes, so a lot of what the 2 docs just told you, I have been through. So I had, back in Christmas time of 2005, I didn't know it at the time, but I had a slip disc. I just woke up one day with it, coming from a very active background, playing high school and college sports. I guess looking back, it wasn't too surprising that that this happened, although I can't trace it to a particular incident or accident that I had. But basically I woke up I'm a high school math teacher, public school math teacher. And I woke up during that Christmas vacation and I could not get out of bed. I had excruciating lower back pain and I could not lift up my left leg. So it went down my left leg as well. And I'm really kind of stubborn. So I didn't want to go to the hospital and deal with it. I kind of just had my husband carrying me back and forth from the bathroom to my bed for a few days till I could get in to see my primary care. And my doctor carried me in, and my husband carried me into the doctor, who promptly said, yeah, you're going into the hospital. So I was admitted. They did an MRI, and sure enough, the disc had slipped. So the surgeon had removed the part of the disc that had slipped out, and I woke up and all the pain was gone and things were great. About 9 months later, the pain reoccurred, went back to see the surgeon. MRI showed the rest of the disc had slipped out. So the surgeon went in and removed the rest of that. And I did not have the same results that I had the first time with the surgery. I did have pain. It continued to get worse. I had tried all of the things just about that were mentioned, physical therapy, TENS units, injections, medications. I finally got to the point where I said to one of my docs, there's got to be something else. Like, I'm too young. I can't handle this. I was out of work. And they said, we think you're a good candidate for a spinal cord stimulator. So now we're into 2008. And I had no idea what that was. They gave me the brochures. There was nothing like this where I could go attend a webinar like this and find out about it. I was just sort of, here's some DVDs to look at and tell us what you think. So I went back to the doc, and once they told me that I could do a trial, for me, after what I had been through, it was really a no-brainer. Like, definitely, let's try it. I really had, for me, I call it the I can try before I buy type thing. So when they did the trial, I literally remember looking up at my doc and saying, and they turned it on in the trial, and I looked up at my doc and I said, why didn't we do this in the first place? It was fantastic. It just completely took me out of pain. My hope was to get off of some of my medications and get back to some of my activities. Much to my pleasant surprise, I was able to get back to all of my activities. And I got off all my medications. And back in 2008, I was on narcotics and some things that I never, ever want to be on again in my life. So I am living pain-free, 100% pain-free. Now, I know that's not a realistic goal for everybody. And it wasn't for me at the time, but boy, am I really grateful. And I do this volunteer as a patient part because basically Boston Scientific and their spinal cord stimulation gave me back my life. Without it, I would not be where I am today. I'm going on 13 years with it, and it's been fantastic. So I have been, as you can maybe see in the slide, kayaking, biking. Last November, I kayaked and biked the entire length of the Florida Keys, about 120 miles in 3 days. With a group called Project Athena. It's been wonderful. So I can't say enough about what spinal cord stimulation has done for me. I know it isn't for everybody, but it certainly was the key to my success and the key to getting me out of pain. So Rachel, thanks for having me today. I'm certainly willing to answer questions people have. And to both docs, thank you as well. It was really informative.
Absolutely. Thank you, Miss Sandy. We were all, you should have seen our eyes when you said you kayaked the length of the Florida Keys. We were like, whoa, that's impressive. So I have lots of questions coming in. We're actually doing pretty good on time. We'll take a few. The first one I'll address to you, Sandy. A patient asked, is it easy to charge your battery?
Great question. So for me, yes, it's very easy. There are two types of charging. There are the sticky pads that you can just stick the charging, I call it a charging puck, right to your skin and charge. And most of my patient ambassador friends that work with me that also talk with patients, that's what they do. I use a charging belt just because I find that's easy. I do it for about a half an hour every other day. So about 2 hours a week. It's easy. I can wash dishes. I can vacuum. I can do chores around the house. I can do all sorts of things while I'm charging. So I don't have to sit and wait and take 2 hours out of my day to do that, or my week, I should say. I just do it and I can do other things. So it's really easy to charge. Very, very simple.
That's great. And that's something us as your local Boston Scientific team, we are on call 24/7, right, Dr. Fox? To help with things just like Sandy was saying, charging, anything with your remote, anything with your programs. That's what we're here for as well. Okay, so let's see. This question is going to be for Dr. Fox. And I'll slide out here. Will I be able to resume my normal activities after the implant surgery?
After the implant surgery, as I mentioned, there would be about a 2-week period where I restrict patients from doing aggressive activities, in particular things that involve bending and lifting. And that's really to allow the skin to heal and allow the device to kind of scar it in place where we put it and where we want it to stay. Showering immediately after the surgery is fine, but no bathing, hot tub, pool, pond where you're going to immerse it. After that 2-week period, at your follow-up, if the wounds look good, then I would release you to any activity that you feel comfortable with. The only restrictions being that if you felt uncomfortable with something and didn't feel like participating, then don't. But as far as whether or not you're going to hurt what I did or hurt the device, no restrictions.
Great, and we'll do this one while you're right here too. Best treatments for arthritis, the spine and joints.
So that's a tough question because if it's just arthritic change that is causing pain in the joints, so that would be pain running up and down the back, then medical management with anti-inflammatory medicines, maybe muscle relaxants, and potentially some steroid injections or blocks can be helpful. If blocks in particular help with that, then ablation of those nerves can be very helpful as well. And those are techniques that Dr. Henick performs. If that arthritis in the joints goes on to the point that there are significant bone spurs that have grown into the area where the nerves live, and they're actually compressing the nerves, or if the joints become incompetent and are unstable, and that's a condition called spondylolisthesis, then surgery is oftentimes the best option for that. That's actually the one condition in the lower back that I probably treat more often than anything else with surgery. So it really depends on the nature of the arthritis in those joints and how much it's progressed and what symptoms it's causing.
All right, now let's see. I'm sure I'm getting some of these. I'm seeing popular questions come in. Dr. Henick, I'll let you take this one. Will spinal cord stimulation allow me to be free of pain medication?
So to be totally free of medication is perhaps a bit of a stretch. Spinal cord stimulators, ideally, we want you to be at least 50% pain-free. Ideally 70, 80% pain-free. If you can come down off your chronic medications to a significant amount, that would be optimal. Minimize the opioids or even decrease or stop the opioids altogether. If you need to continue on with the neuropathic agents like gabapentin, the non-steroidals like Motrin, ibuprofen would be ideal. Hard to come off your medications altogether, but some people like Sandy obviously is able to do it, which is great. Okay.
So we've got a lot of very personal medical questions. I will try to address those individually. And what I would suggest to these patients, make an appointment with either Dr. Fox or Dr. Henick. So that way they can really address the personal medical history that's going on and point you in the right direction. One thing that I am seeing, and I'll let either one of you take this, if I've been through the RA and injections that did not help, what is the next step? Haven't been given pain meds, but lower back constantly hurts. Whoever would like to take that.
So this also kind of depends on what the symptoms are. And it sounds here like it's mostly back pain. If there is a condition there that is causing some compression in the nerves, a surgery might be appropriate. If not, and it does look like you've been through some extensive treatment, then spinal cord stimulation would be a very reasonable option for this.
Sandy, this is a question for you. How old was Sandy when she first had surgery and then spinal cord stimulation? You can fudge the number if you'd like, Sandy.
So yeah, I'm 54 right now. I'm not afraid to say that. So it was I was 40 when I had the first surgery. When I woke up, when I had the slip disc, my L5S1, and 9 months later I had the second surgery, and I did not get the spinal cord stim, and that was 2006. Beginning of 2006, I did not get the spinal cord stimulator till the end of 2008 because I had gone through 2 long years of all those other things that I tried that were unsuccessful. So 42, I had the spinal cord stimulator.
Gotcha. Thank you. Dr. Fox, you may want to do this one. I had an L3-4-5 fusion 2 years ago. I can only walk about 100 feet, stand still for 10 minutes. I'm in pain, can hardly walk back to my house. Suggestions?
Yes, so this would be something that we really need to drill down on. What's the source of that? And your inability to walk 100 feet makes me concerned that there may be some residual or new onset of some narrowing around the nerves and what we call neurogenic claudication. And that's something that can be assessed with an MRI or maybe a CAT scan, since you had a fusion surgery a while ago. So the key to this would be to figure out why is that. And if it truly is the muscles that you're describing, then spinal cord stimulation would be a reasonable option. And having had an extensive fusion like you describe here, that is oftentimes the case, that folks are left with some chronic pain that is related just to the surgery itself. So I think first off, drilling down on why you're having these issues. If there is something that can be treated with injections or surgery, consider that. If not, a trial stimulation would be a reasonable thing to do.
All right. I think we've covered most of them. Let me just scroll here. A lot of people saying thank you. You're welcome. Thank you so much to our presenters. Thank you, Sandy, for sharing your story and sharing your time. Make sure we're not missing a slide. Oh, this was the question slide. You can see Dr. Henick's kids up there. Dr. Henick said you could see the different seasons of life that the two physicians are in. Dr. Fox is flying planes. Dr. Henick is raising 4 kids. So we've been through everyone's questions. If we missed any individual ones, I'll try to get back to you, see if you'd like to schedule an appointment. Also, Dr. Henick and Dr. Fox's numbers right there, 547-5145. You can also check out Control Your Pain to see physicians in the area that do spinal cord stimulation. Thank you again for joining us. We will also be sending this out in a recording. So if you want to share it with friends or share it with loved ones, watch out for your email for that. Thank you very much, everybody. Have a great night.